All right, today we're going to take you inside one of the most intense places in all of medicine. We're talking about the high-stakes world of trauma surgery, and we're zeroing in on catastrophic abdominal injuries. It's the question surgeons face every single day. A patient comes in with massive internal bleeding, and just like that, the operating room turns into this theater of controlled chaos. It's where skill, strategy, and pure speed all have to come together perfectly. So let's really dig into what that looks like. So, get this clinical phrase from our source material, it just paints such a vivid picture. I mean, just imagine the surgeon making that very first cut. The lining of the abdomen is literally bulging. It's bluish from all the pooled blood. And the second it's opened, whoosh, all that pressure releases in a rush. And right there, that's where the battle truly begins. You see, in situations like this, absolutely everything revolves around one single core concept. And as you're about to see, the clock isn't just ticking, it is completely unforgiving. Yeah, every single second that ticks by means more blood loss, the patient's blood pressure is dropping, and their organs are just being starved of oxygen. The damage can become permanent in a matter of minutes. So the whole procedure, it's not just a repair job, it's an all-out race.
Okay, so problem number one is immediate, and it is absolutely overwhelming. How do you possibly stop what is essentially a tidal wave of internal bleeding? Before you can even think about fixing anything, you first have to get control.
Well, for a severely injured liver, which is one of the most common and, frankly, bloodiest injuries out there, surgeons often turn to a classic technique. It's called the Pringle maneuver, and it's an absolutely crucial first move to just pause the bleeding for a moment. And what's so cool about this is how simple the idea really is. You literally just clamp the main blood vessels that are feeding the liver, and you starve the bleed. It's that straightforward. This one simple move is often the difference between total, uncontrollable chaos and giving the patient a real fighting chance. It's just an elegant, powerful way to buy that precious time they need to see clearly and start figuring out the repair. The whole strategy is simple, right? Stop the flow, then find the source. So once that immediate massive bleed is under some temporary control, the next problem pops up. The surgeon now has to switch gears and become a detective. Their job? To quickly and accurately figure out the full extent of the damage that's hidden deep inside the body. And to do that, you need a map. A really important part of that map is for an area called the retroperitoneum. The best way to think of it is like the body's hidden backstage area. It's tucked behind the main abdominal cavity, and it's where all the big-ticket items live, like the aorta and the vena cava. And surgeons have this area divided up into 3 distinct zones. And this is where their strategy gets really brilliant. Let's say there's a hematoma, a pool of blood in zone 1. That's a mandatory green light. You always go in and explore, no questions asked, because that's where the body's main pipelines are. But for zones 2 and 3, it's more of a yellow or red light situation. The decision really depends on the type of injury. A gunshot wound? Yep, you're going in. But a hematoma from, say, a car crash that isn't getting bigger, you might actually leave it alone because going in could just cause more bleeding. Now, this kind of decision-making, it's not just guesswork. Not at all. It's backed by a huge body of evidence. In fact, to give you some perspective, the latest guidelines from the European Society for Vascular Surgery on just this topic, they contain 105 official recommendations. Wow. So let's take a look at a few of the most critical ones. The Class 1 recommendations. Is the patient unstable? You go straight to the operating room. There's 0 time to waste on scans. Is the patient stable? Okay, then a CT scan is the absolute gold standard to map out the injuries. See a hematoma that's getting bigger or even pulsating? That's a blaring signal of a major active bleed that has to be found and fixed right now. This is quite literally the surgeon's playbook. All right, so you've gotten a handle on the initial bleeding, and you've mapped out the damage. Now comes problem number 3. How do you physically get to these deep, hidden injuries to actually repair them? This is where we see some incredible surgical choreography. Let's take a look at what these signature moves look like. So first up, we have the Maddox maneuver. To get to the aorta, that's the body's largest artery, remember, on the left side, the surgeon makes a cut along the colon and then literally rotates the spleen, pancreas, stomach, and the colon over towards the middle of the body. And just like that, the entire length of the aorta is exposed. Incredible. And what about the right side? Well, for that, there's a kind of mirror image move. The cattle brash maneuver. This time, the right side of the colon and the small bowel are moved out of the way to expose the inferior vena cava, the body's largest vein, and all the other structures on the right side. Look, these maneuvers, they're not just procedures, they are pure surgical artistry. They let a surgeon safely lift and rotate a whole stack of organs right out of the way. Why? To get a completely clear, unobstructed view of those critical structures hiding underneath. It is a breathtakingly bold and incredibly effective strategy. These techniques are, without a doubt, life-saving. But this brings us to our final and maybe most unexpected problem. And this one isn't about a single patient on the table. It's about the future of the entire field of trauma surgery. And here's the crazy paradox. Because modern medicine has gotten so good at managing injuries without surgery, the number of these huge open trauma operations is actually going down. And that raises a really critical question. How on earth are young surgeons supposed to master these incredibly complex, hands-on skills if they see them less and less in the real world? Well, one of the most powerful solutions out there is something called the Advanced Trauma Operative Management Course, or ATOM for short. It's this incredibly realistic high-pressure simulation. Trainees walk into a full-on operating room environment, and they have to repair a series of complex, life-threatening injuries on a live anesthetized animal model. And of course, it's all against the clock. It is as close to the real thing as you can possibly get without having a human patient on the table. And that really brings us full circle, back to our central theme. The art of trauma surgery is more advanced and sophisticated than it's ever been. But as that very success creates a new training gap, the challenge for today and for the future is this. How do we make sure that the next generation of surgeons is always prepared, always ready, and always able to win that desperate, desperate race against time?